Hello. So I'm going to talk about it keeps getting better for overweight treatment, and we're going to talk about Zepbound. And of course, that's tirzepatide, and that's the agent that we've known and used already in the context of diabetes. It's Mounjaro. And I do want to tell you, thank you very much for tuning in to Cardio Visual. This is the app where you can learn a lot about cardio and also about metabolic and about diabetes. My name is Tom Blevins, and I'm at Texas Diabetes and Endocrinology. I call myself an endocrinologist, although increasingly I'm starting to think I should say that we are metabolic endocrinologists. We do diabetes, we do lipids, we do weight, we do all those things. We've been very fortunate here in Austin to have participated in a number of the weight loss trials, including the one concerning the agent that we're going to talk about. And last time, if you were on, you recall that we talked about Wegovy and Ozempic and a little bit about Mounjaro. And so the focus then was Wegovy and Ozempic. Great drugs. I mean, these are great drugs. They lower glucose, and that's one thing I really like to do, and they also lower weight, and that's something we all like to do. And this time we're going to talk about the newest information concerning tirzepatide. And of course, tirzepatide is Mounjaro on the diabetes treatment side, and tirzepatide is now Zepbound on the weight loss side. So we're going to talk about this agent. And again, if you're just tuning in, Tom Blevins here, we're going to talk about Mounjaro, we're going to talk about Zepbound, and we're going to talk about, of course, the name of the drug is tirzepatide. I would say stick with the name Zepbound. Zepbound is what we're going to talk about for the most part. Let me make a few points. Never would have a complete talk without talking about obesity and its complications. And this is something we all treat. I mean, I treat people with diabetes and overweight. You do the same thing, lipids and overweight, blood pressure and overweight. And now we all treat people and try to treat people with overweight. And when people gain weight, what happens to their body? Everything goes kind of different. It's just not normal. People can have a higher risk you can really go down every single system in the body, and overweight affects everyone in a negative way. Migraines, pseudotumor cerebri, depression, anxiety, things like that happen in people with overweight. Cardiovascular, hypertension, coronary disease, congestive heart failure, even PE connected to overweight. GU, stress incontinence, even some connection with hypogonadism and prostate issues. And then, of course, fertility issues as well with polycystic ovarian condition, pulmonary obstructive sleep apnea. You could go on and on. This is what we treat. We treat people, and we treat all of the complications of overweight. And it'd be nice just to treat the overweight. And that's where this all goes. Renal nephrolithiasis, proteinuria, CKD, even connected to overweight. And GI, of course, the NASH, which is now MASH, metabolic associated steatohepatitis, and the fatty liver thing. It's all connected. And then, not to mention GERD and reflux. So when we treat people in our offices every day, we're treating each of these issues. These are many times downstream of overweight, and it's been really difficult in the past to treat the overweight. We do know that when it comes to weight loss goals, we talk about percentages, and that's what I'm going to talk about mostly today is percentages of weight loss and weight change. Now, we also like to talk about pounds, but we're going to mainly talk about percentages. But we know that if a person has pre-diabetes, if they can lose about 10% of their weight, they can prevent diabetes. That's been seen in trials. We know that even type 2 diabetes can be controlled so much easier and so much better when people lose weight. Hypertension, 5 to up to 15% of body weight loss can lower and normalize blood pressure. Not for everyone, of course, but in general, this is quite true. We also know that obstructive sleep apnea gets a lot better if people lose somewhere between 7 and 11%. This is based on a number of studies. And then osteoarthritis, all these things. We always think about diabetes, blood pressure, lipids, but what about the rest of the body? The body just is not normal when people are overweight. And we struggle and struggle, and the people we treat struggle and struggle to lose the weight and to try to make things better. Lipids are better if people lose 5 to 15% of their body weight. And then We know that fatty liver and this steatohepatitis, which is becoming the most common cause of cirrhosis, we know that that condition is better and improved and reduced. The inflammation is reduced, the fatty infiltration is reduced when people lose anywhere from 5% up to even, some studies would say it may take much more, like 30% of weight loss to normalize or improve. But weight loss is such a big component of improving things. So now we have this agent, Zepbound. What is Zepbound? And let me talk to you a little bit about that, and then we'll tie this all together. We're going to talk about a few of the studies. In fact, what I'm going to do, the subject is we're talking about Zepbound for treating people with overweight. As somebody just asked, what's the subject? I know people are coming on a little bit after the hour to catch up. We're talking about Zepbound. We're talking about obesity. We're talking about treating obesity. We're talking about really, it's a new world. And it's a hugely new world. It's just not a little bit better. I think it's a whole lot better. So Zepbound, it's a long-acting med. It has a half-life of 5 days. It's once a week, injections. It's an injection. And remember, Zepbound is tirzepatide, and it's the same thing as Mounjaro. The FDA requires that the companies give medicines different names or different indications, even though it's the same med. And it's a combination. It's what we call a dual agonist, meaning it has properties like GLP-1, like the other GLP-1s, glucagon-like peptide-1, and we use those rampantly for treating diabetes and now for weight. And again, just for those of you who just come on, we talked about Ozempic and Wegovy last time. That's the same thing too. That's semaglutide. And now we're talking today about tirzepatide. And it just got a new indication not long ago. And so this agent is a GLP-1 and also it's a GIP agonist. And that means, that's GIP, what is that? Glucose-dependent insulinotropic polypeptide. Don't even think about that word. Just think GIP. So it's a combined, and when you combine those together, remember once a week, and you don't have to adjust the dose to renal or hepatic function, they're not metabolized there. That agent, that combination can not only reduce appetite by a central nervous system effect, it can reduce food intake as a result. It slows down gastric emptying, making people get full faster. This is a story of GLP-1, but this agent has the GIP effect too. The GIP increases insulin sensitivity. It seems to also have a central effect on appetite. And so the GIP and GLP-1 combination really can be very, very potent. And also, of course, this agent can stimulate insulin production, lowers glucagon, lowers hepatic glucose output. And again, as I mentioned, slows down gastric emptying. So it does slow things down with the stomach, increases satiety, and also reduces appetite. We know, and this is a study that was done comparing the Mounjaro, which is tirzepatide, same thing as Zepbound to Ozempic. We know that the A1C lowering is quite substantial and seemed to outperform a little bit the Ozempic. And the Ozempic was handicapped by only having the 1 milligram dose in this study, but also at the same time, the weight changes were just phenomenal. And this was a study in people with type 2 diabetes. Weight change was like 11.8% of body weight. And, we used to, we struggled. I'm going to emphasize this a few times. We struggled with 5% weight loss. 5% weight loss is so good. 7%, that's great. And then people don't maintain it after that. We're now talking like 12% weight loss at the higher dose. And you're going to hear some other numbers here in a minute. And this is in people with diabetes. And so that turned into like 25 pounds in people at the highest dose. So in fact, in that study I'm talking about, they compared the Mounjaro tirzepatide to the Ozempic, the semaglutide. About 36% of people actually lost more than 15% of their body weight. Now we're getting into some real high numbers. And then along comes the series of studies with tirzepatide, which is Zepbound, Zepbound, that got it approved for weight loss. Now it was approved for diabetes based on some of the studies I talked about before. Now it's approved for weight loss. So there's a study called the SURMOUNT-1. And these are people who don't have type 2 diabetes, and they're going to be placed on essentially on the Zepbound or tirzepatide versus placebo, and they're going to be followed over about a 72-week period. So here we go. And these people had to be overweight to get in. I'm not going to go through all of the entry criteria. They had to have a BMI of over 30 without comorbidities, or they had to have a BMI of 27 with those comorbidities like hypertension, hyperlipidemia, things like that. And they could not have diabetes to be in this study. So now we're talking about really good weight loss in people with diabetes, but now we're talking about a study in which people did not have diabetes. So what happened? Well, over 72 weeks, the people in the 10 and the 15 milligram dose lost about 21 up to 22.5% of their original body weight. Think about that. I mean, I'm just saying that casually, 21, 20, 22.5. That's huge. It's gigantic. And, you know, we've talked about, 5%, we'd be happy with 5%. Now we're looking at an agent in people who don't have diabetes. It turns out that people who don't have diabetes probably lose weight a little bit more than people who do. Both weight losses are great, but now we're looking at people who don't have diabetes. And if you translate that into pounds, you know, I like percent because it tells you relative change from the baseline. And it gets into the idea of, we want people to lose 5% at least to get a benefit. Well, now we're looking at 22.5%. And if you look at the mean pound weight loss there, what you find is that the people on the higher dose lost about 48.1 pounds. And the people on that's the 15 milligram. The dosing for Zepbound is just the same as the dosing for Mounjaro. It's the same. And the people on the 10 milligram dose, I think, lost about 44 pounds. So that's kind of what was going on there. And so very, very substantial weight loss here. Now, people say, it's both lean body mass and fat mass loss, boo-hoo. But the truth is, it's not. If the body weight composition and body composition was looked at in the study, and it was way more fat loss than lean body mass loss. Now, when people lose weight, they can lose lean body weight because they don't need as much muscle sometimes to carry them around. That happens, but it was vastly more fat mass loss. In fact, it was like a selective effect in a way, if you look at the data. And I encourage you to look at the data. This is the study called the SURMOUNT-1, and their body composition data was really interesting. And so that's an important point to make. I get asked that question all the time. I think it's muscle mass loss too, isn't it? And the answer is, in these studies, if you look at the objective data, it's fat mass loss. And that's what you want. Okay, then along comes the SURMOUNT-2, another weight loss study. And it actually is in people with diabetes, a different study than the one I told you about before. And these are people with obesity and type 2 diabetes. And they're, once again, this is a simple study. I mean, they're placed on either tirzepatide or left on placebo. And what happens over time is a very similar picture. And I'm just going to talk about the percentage of people that lost greater than or equal to 5% of their original weight was 82% at the high dose, 79% at the 10 milligram dose. So the higher doses are going to be 10 and 15 milligrams, as you know, if you've used Mounjaro. So this is purely a weight loss study, though, with people with type 2 diabetes. And greater than 10% of their original body weight loss in this study in the people with diabetes now was 60% and 64.8% in the people at 10 and 15. Greater than or equal to 10% loss, 2/3. That's phenomenal. I mean, phenomenal. Wow. I mean, what other words can we use here? And the percentage of people that lost greater than or equal to 15% of their original body weight, 39.7% and 48%. That's phenomenal. Now, what about over 20%? Do you think very many people lost over 20% of their original weight in this study? Yeah, they did. 21% and 30.8 at the 10 and 15 milligram. So really good weight loss. And you all know that when people with type 2 diabetes lose weight, what good things happen. Good things happen to everybody. But people with diabetes, good things happen. The A1C at the start of the study was around a little over 8. At the end of study, in the people on treatment, it was down to 5.8, 6.7. A vast improvement in the A1C, and as expected. What other things would you want to look at in a study like this? Maybe lipids. What happens to lipids when people lose weight? Well, duh, we know what happens, but I can tell you what happened in the study. The triglyceride level dropped considerably, down about 27% in the people on treatment. The VLDL, which is kind of triglyceride anyway, dropped also about 26%, Free fatty acids dropped, HDL went up about 9%. And so what happened is what you figured would happen. And things got a lot better. What about blood pressure? This is another kind of a duh. I mean, fortunately, it's measured. You want to quantitate it and find out. But when people lose that kind of weight, what happens? Well, the systolic blood pressure dropped about 6 millimeters of mercury, mean 6 millimeters of mercury in the people on the 10 milligram, and about 7.7 of the people on the 15 milligram. So all those things got better. All of the comorbidities got better. The diabetes got better. The weight went down. One of the endpoints was not sleep apnea here, or other endpoints like osteoarthritis. I kind of wish it had been, but it wasn't. We know those things probably got better too. Now there are two more studies I want to talk about, and then we'll talk some general stuff, and then we'll close and I'll take questions. But the other study is called the SURMOUNT-3. So we talked about 1 in people who don't have diabetes, 2 in people who do have diabetes. Now we're talking about the SURMOUNT-3. Now this was a really interesting study in which people who didn't have diabetes were placed on intensive lifestyle for about 12 weeks. Then they were randomized into the study. So intensive lifestyle was like intensive diet counseling, encouragement to exercise, and all that stuff. And so this is a very holistic study. So they go into a weight loss phase, and then if they achieve more than 5% of their original body weight loss with this approach, this intensive lifestyle, then if they do that, then they're randomized into the study. Now, the study was either Zepbound or placebo. And so let's take a look at what happened here. So this is like kind of what we ought to do. We get people to lose weight on their own. And then you know, depending on how well they do, we might enter them into treatment. And the treatment would be maybe Zepbound. And so what happens here with the SURMOUNT-3? Well, if you look at the body weight loss after they were randomized, after the intensive lifestyle, it was about 21% in the people, from baseline, in the people on the tirzepatide, that is the Zepbound. The people on placebo actually gained a bit, about 3%. No surprise. And this just confirms the idea that this stuff worked even after intensive lifestyle. And then if you look at the actual weight loss from the time they started the program until the time they finished, and the ones that went on the Zepbound, the people lost about 26.6%. So people did lose weight with the intensive lifestyle, and then when you added the Zepbound, they lost more weight. No surprise. And again, I'm talking about these numbers. Sit back and think about this. We're talking numbers like 20% weight loss. We're not talking 5 or 10. You know, in years past, this is a revolution of sorts when it comes to weight loss. And now we're talking about like, oh yeah, 20%. But I know you're not thinking that way. I would have been ecstatic in the past to have an agent that caused people to lose 5 to 8%. And now we're talking considerably more than that. And I'm talking percentages. And you know, these are, you could go and look at the study and look at the pounds too if you want to. So that's the SURMOUNT-3. That's the intensive weight loss, and then placebo versus Zepbound. There's one other study I want to talk a little bit about, and this was one that was just presented no more than 2 months ago at the European meeting, among other places, diabetes meeting actually. And this is a group of people who actually are just overweight, and they're entered into a study where they're treated. Everybody gets tirzepatide for 36 weeks. Everybody. And then at 36 weeks, people are randomized into a maintenance phase with tirzepatide, which is Zepbound, or they're placed on placebo. And so what happens? Well, you know, at 36 weeks, what happens is what you'd expect. The people on the agent, and that was everybody, lost about 20.9% of their original body weight. Very consistent finding. Remember, this 20% thing, huge. It's really huge. And so the bottom line is that, and again, this study addresses, it doesn't completely answer, but addresses the question, how long do you treat, and then what do you do? Do you keep people on the medicine to maintain the weight? Does it work or not? What do you do? And, you know, this is a complicated question, and the answer is this has to do with cost, compliance, all those things. And we're not going to get into all that today. We'll do that at another session. But essentially, I can tell you to make a long story short, again, I want to go back and review this. Everybody goes on 36 weeks of Zepbound. And then half of the people continue on Zepbound at 10 or 15 milligrams weekly. That's the so-called maintenance phase, maintenance use of the med. And the other people go on to placebo. Now, what do you think is going to happen here? And you know, we looked at this data with Wegovy last time I talked, and the people who stopped the Wegovy gained the weight back for the most part, not all the way, but nearly all the way. And that's kind of what you'd expect. I mean, like a chronic condition, obesity is a chronic condition, and to continue the effect that you get originally, you probably have to keep the agent going. Things aren't going to magically improve. And some people can actually magically take care of things and really change what they're doing, their lifestyle, but not everybody. So what happened here, again, this is the maintenance phase question. What happens? And the answer is what you would think. About anywhere from 88 to 93%, depending on how you read this data, of people who continued on the tirzepatide not only maintained the weight, they maintained it. The effect didn't go away. Okay, that's one thing. But they also lost a few extra pounds. And it turns out that only about 13.5% of people in placebo actually maintained their weight. And there's a few statements to make, is that the people on tirzepatide or Zepbound had about a 5% additional weight loss as they continued on it. And the high percent at the bare minimum maintained. The placebo group regained about 14%. And they were on their way to regaining between week 36 and week 88. And there's a conclusion there too, is that is interestingly, you know, a decent percent of people on placebo actually maintained a degree of their weight loss, which is a big deal. And so the weight didn't just go, you know, skyrocketing back up. Many people kind of tended to regain a good bit of their weight, but at 52 weeks after they went off the medicine, actually quite a few did not return to baseline weight. They still maintained a little bit. So that's a really interesting study. Now, you know, you may ask, and I ask myself, what about after 88 weeks? Now what? After that, I think you're going to have to continue the medicine to maintain what you gained. So that's the data I want to present. I want to cover a few things regarding this agent, just so for you to know. The new agent, Zepbound, is indicated for weight loss for people who have a BMI of 30 or greater, or people who have a BMI of 27 or greater with comorbidities. So that's pretty typical. And the comorbidities are the typical ones, like diabetes, like hyperlipidemia, like hypertension, things like that. I guess you could even call sleep apnea one. You might have to document that. Now, coverage is, who knows? I'm not going to answer that question if you ask it. By the way, I don't know how well it's covered, and the cost is another issue, another discussion. The recommended starting dose is just the same as Mounjaro, 2.5, and go up every month up to 15 if that's the dose you want to go to. This contraindication in people with medullary thyroid cancer in their family history, or in the multiple endocrineoplasia, if they have that in the family, there's still a contraindication there. And really, the product insert of Zepbound reads almost exactly, except for the data in the studies, reads the indications, the warnings and things like that pretty much read exactly like the Mounjaro. And the thing about advise females using oral contraceptives to switch to non-oral, or add a barrier method of contraception for 4 weeks after they start or after they titrate the dose, that's still there. There is a discontinuation rate. And in that first study we talked about, you know, great results, but some people can't tolerate, you know why, it's GI. And in fact, about 4.8% of people discontinued at the 5 milligram dose, 6.3 at the 10 milligram dose, and 6.7% of people discontinued because at the higher dose, the 15 milligram dose, because they couldn't tolerate it because of GI side effects. So, you know, not everybody can take it. And it's a great drug, and it's great results, but not everybody can take it. The most common adverse events are going to be nausea, diarrhea, vomiting, constipation, and up to 25%, 20, even 30% of people had nausea. Now, the nausea, when you look at nausea in the studies, most of the time it got better. So it doesn't mean it just continued on and on. Nausea was defined typically as one or more episodes. But then some people went on to discontinue because they couldn't tolerate it. Gallbladder disease, 1.1% in people in Zepbound, and a little bit lower in people on placebo. So keep that in mind as well. And the side effects are mainly GI, and that's true. And that's true of Mounjaro. That's true of Zepbound. That's true of course, they're both tirzepatide. So one question again is, what happens after the treatment is completed? And what is completed? I don't even know. I think people have to continue taking it to maintain the effect on their weight. And cost and availability questions, these are all, this is a wonderful medicine. I'm near the end here, but I'm going to summarize by saying it's a wonderful medicine. We're seeing percent weight losses like we've never seen before. It's a new world, and it's exciting. It's really exciting for our patients when they come in and they've lost the weight, their diabetes is better if they have it, their blood pressure is better, they feel better, they feel more positive, their lipids are better, and I don't have a study yet to tell me that their joints are better, but they probably are. And I tell people who have back pain and have these, the protuberant abdomen, hey, lose weight. That's going to help your back. It's got to. So this is a great medicine. Now we have to kind of learn how to use it. We have to learn how we can get our patients, how we can make it affordable and covered and all that. And those are challenges. We always have challenges. I'd rather have a medicine that causes 20% weight loss and have the challenge of getting it covered than not have a medicine at all. I mean, with no challenge of getting it covered. We spend a lot of time in our practices getting things covered, as you know. So thanks for tuning in. That's it. That's a kind of a very high level coverage of those studies, I agree. But I wanted to cover those. Thanks for tuning in to Cardiovisual. This is the app that shows you and gives you lots of information concerning cardiology, as I said earlier, metabolic conditions, lipids, diabetes, and then weight loss. And we talked about the latest information concerning Zepbound, and we'll have other topics down the road. So thank you very much. At this point, I'll take questions. And I'm going to look and see. Does prediabetes count as a comorbidity? Yes, it would. I would think the comorbidities would include prediabetes. It would include lipids, hyperlipidemia, hypertension, and you could probably throw in, I think you could throw in sleep apnea. And there may be others that might make it. And what effect, another question I see coming through is, what is the effect of I think, GLP-1s as a weight loss agent for hypothyroid patients? These medicines don't directly affect the thyroid. There is a contraindication for medullary thyroid cancer. That's it. No other thyroid cancer. They don't affect thyroid function. They do slow down gastric emptying. And so, medicine like thyroid hormone has a very narrow therapeutic index, and you just have to, you might want to monitor the level, but I can tell you that in clinical practice, it doesn't seem to be a major issue. Thyroid hormone ideally is given by itself first thing in the morning. And so its absorption, its presence in the GI tract, upper GI tract, kind of takes precedence, and that allows it to get absorbed. Great question. And type questions in the comments, if you would, the comment section there, and we can answer them. And one question I get very often is, if you have a question, type it in the comments part there. And the other question I commonly get is, what about the long-term? And we have data now out to 88 weeks, and that's about as far as it goes. And we need longer, that is for sure. I think the concept that is kind of exposed in this study that we talked about is that you have to keep the medicine going to maintain the effect. Although going off doesn't lead to just rapid weight regain. And we don't know. Should people go on and off and on and off over time? We don't know. I can say to 88 weeks, it's very clear that the weight maintenance, the weight loss is really good. First of all, remember that study, 20-something% weight loss, and then the weight maintenance, 93% of people maintaining their weight loss for 88 weeks is phenomenal. Phenomenal. What are the mental health benefits of Zepbound? Well, interestingly, something that is now in the product insert, and I'm going to continue to answer the questions. If you need to go for it. Appreciate your time on here, and I'll go for another maybe 5 minutes answering questions if you like. But in the product insert, there's something about be cautious if a person has significant depression, because especially if they're suicidal, because weight loss studies have shown, other weight loss studies have shown that when people get on weight loss agents to lose weight, it can affect them, and they may not exactly know how to deal with that. So they need to be counseled carefully. They need to be very attentive to the idea that people who are very depressed or something, when they have a weight loss or they're on a weight loss agent, there may be changes in their profile, their psychiatric profile, that could go better, could go worse. And so they need to be seeing somebody. But as far as effect on mood in general, I don't have a study to show you, but I have clinical experience. When people lose weight, they are happy. They are happy. Sometimes the people around them are not ecstatic because they kind of see them in that role. You're overweight. Now you're losing weight. What? But they're happy. And they tend to improve their mood. But do keep in mind that people have significant major depression. You really want to be sensitive with any weight loss approach, really, to that they may need additional attention. Let's see, how does it impact the heart? Weight loss is going to help the heart in so many ways, and that it's going to reduce lipids. That should reduce cardiovascular risk. We don't have a cardiovascular outcomes trial yet complete for tirzepatide. We don't. Remember, with semaglutide, the cardiovascular outcomes trial looked good. Fewer major adverse cardiovascular events, no surprise. And I sort of think it's going to follow the same way here with the tirzepatide, but we don't have the outcomes trial yet. If the lipids get better, the blood pressure gets better, fluid status gets better, blood sugars get better, everything should be better for the heart. And there may be some direct effects too, but I'm not going to get into that, and that's really kind of unclear because there are receptors for GLP-1 in the heart. Now, any cases of intestinal obstruction, definitely cases of slowed down gastric emptying and slowed intestinal function, and out and out obstruction, I'm not aware of those. What is called obstruction and what is called slowed function, sometimes there's a big blur, and so keep that in mind. But if people have significant slowing or anything that smacks of obstructive symptoms, then I think I would discontinue the medicine. And how would I compare Ozempic and Zepbound? There was this study that I mentioned early on that was in diabetes. They're great, both. First of all, they're both great drugs. In a way, why compare? They're both great. They do a great job. If you look back at the study I went over earlier, and again, Ozempic was a little bit disadvantaged by the fact that only 1 milligram was available at the time of the study. If you compare that, though, to the tirzepatide and Mounjaro, the tirzepatide outperformed a little bit in terms of A1C and also weight. But they both did really well. They're both great drugs. And let's see. Let's take one more question. And I think, let's see, Liz, could you thumb back? I can myself. Let's see, here we go. I can do that. Does it help increase flexibility and strength? No evidence for that. I mean, I would encourage people who are losing weight to exercise and try working out to improve their strength and flexibility. And does it help with stress reduction? Not directly, but this is my last question. Not directly, does it help with stress reduction? I would say not directly. I don't have any data to show you there. But when people successfully lose weight, they become, not my favorite word, but they become empowered. They feel in control. And, they control their appetite, for one thing, and they lose weight. Appetite is a demon. And does that reduce stress when you control appetite and lose weight? I think so. So I think in a way, in my opinion, without data to back it up, is probably so, depending on the individual. Well, again, thank you very much for tuning into Cardiovisual. Tom Blevins here, and we'll go ahead and sign out. Look forward to talking to you at a future date.